So in good old days, patients had the choice to choose only their doctor. The surgery was same, but now they're spoiled with choices. Not only they have to choose the doctor, they have to choose the surgery, the lens, and therefore their expectation is also increasing, and they're no more happy with the 20/20 Snell's visual acuity. So we get a lot of patients who say, well, my vision is okay, but my images are not that clear. So if we analyze the cause, one of the main reasons why the vision is not clear is because of aberration. When I was reading about aberration, I remembered Sir Truman had said, if you cannot convince the Senate, confuse them. In science, obviously, you cannot remain confused. So let's go into aberration in little more detail. Human eye is the most complex and most imperfect optical system. This was a statement of Sir Duke Elda. Dr. Jarnicke said, optical aberration is the departure from an optical system for producing aberration, a image which is not sharp. So aberration can be analyzed most commonly by Jarnicke polynomial, and it is expressed in root mean square. It is measured either by point spread function or by modular transfer function. So there are 16 grades of aberration. 0 order to first order are called constant aberration. Second order are the lower order aberration. Third order and above are called the higher order aberration. 0 order aberration is called piston, and order 1 is tilt and tip. Second order are defocus and primary astigmatism, which can be corrected through spectacles. Third order is coma and trefoil. Fourth order are spherical and chromatic aberration and quadrifoil, secondary astigmatism. These are corrected by surgery. Fifth order aberrations are requiring neuroadaptation. So what is a piston? Piston tilt, as I said, when you look at the point spread function, the focus is like a point here. But the point spread function in all other aberrations are more, especially if you look at the central triangle, the point spread function is worse. So let's understand what is tilt. It is a physiological aberration where the nearby objects appear bigger and the further objects appear smaller. Defocus, we all know, is when you look at an object and it is not focused either by myopia or hypermetropia. These are defocus, and if it is not focused in one particular axis, it is called astigmatism. Coma and trefoil is when you look at light and you see the light spreading out, it is coma and trefoil. Spherical aberration, we know, is the central rays focusing at one plane and the peripheral focusing in another plane is called spherical aberration. Different wavelengths of light focusing at different planes are chromatic aberration. And all these higher order aberration cause photic phenomenon and difficulty in quality of vision. There are various causes in post-cataract scenario which can cause aberration. From corneal surface, dry eye has been covered by Praveen. From the wound, from pre-existing spherical aberration and aberrations induced by lens, chromatic aberrations caused by IOL tilt and decentration, and most importantly, use of premium IOLs when angle alpha is big. I'll not go into details of dry eye aberration. We all know dry eye causes aberration, especially the coma and trefoil, and lubricating drops do improve these aberrations. It has also been seen that dry eyes not only increase aberration, they also decrease the vision-related quality of life. Wound, we know in SICS, the corneal wound can cause astigmatism. In addition to that, it can also cause coma and trefoil, and it is mostly from the posterior surface of the cornea. Higher order aberrations are present in eye, and intraocular lenses, our choice can worsen it. We know that natural cornea has about plus 0.25 spherical aberration, and lens can neutralize minus 0.2. Whereas when the cataract develops, it becomes more positive and worsens the higher order aberrations. So when we compare post cataract surgery patient with a cataract patient, obviously aberrations decrease. But with a normal patient, if you compare a pseudophakic eye, aberrations are still present and they can cause reduced contrast sensitivity. If you look at a simulated chart from the eye trace is a machine where you can segregate the aberrations from total aberration to internal and corneal aberration. So if you see here, this is the internal aberration, so this is the corneal aberration, this is internal aberration, and this is total aberration. So if you remove the lenticular aberration and put a lens which can neutralize the corneal aberration, then you get a lens, the image which is good in quality. The eye trace can also give aberration in forms of map, where you can see the corneal, the external aberration or corneal aberration is quite smooth here, whereas the internal aberration is more. In this case, if you remove the lens and put a lens which does not have aberration, you can get good vision. It can also give in form of chart. This is internal aberration, this is corneal aberration. It is high here. The aberrations being high, in this case, if you put a higher lens of premium IOL, then the patient may not be happy. But here, if you see, the internal aberrations are high and the corneal aberrations are low. In this case, the patient will be happier. In addition to the higher order aberration, you must look into corneal spherical aberration, which is expressed in the plus number mostly. Try to neutralize it with appropriate IOLs. For a plus spherical aberration, use a negative spherical aberration IOL. And for others, accordingly, choose your IOL appropriately. If the residual spherical aberration, which is after neutralizing the corneal aberration, is 0, try to target plano refraction. If it is negative, then try to target a plus spherical aberration for a 0.1 micron. And if it is positive, then target minus 0.25 for a 0.1 micron. And this is important for LASIK eyes, post-LASIK eyes, because hyperepic LASIK causes minus spherical aberration and myopic LASIK causes spherical aberration. Let us look into tilt and decentration. We know that decentration more than 0.5 can lose the effect of sphericity, and tilt also causes significant amount of coma. And lastly, it is the angle alpha. Angle alpha is important, is basically the difference between the optical center and the patient's visual axis. And if it is high, normally they are very close to each other. If it is high, then the light ray in the multifocal lens, instead of passing through the center, will pass to the border of the bullseye. That will cause too much of refractive problems. And in an actual scenario, if you look at the microscope image, the Purkinje image from the cornea, which is the triangle here, and the Purkinje image from the lens, which is not a triangle. So in that case, you can see that these two images should be within the bullseye. Then you are sure that this patient will not have too much of aberration induced by lens. Chromatic aberration does play a role, and a normal crystalline lens has a chromatic aberration of 47, and we must try to put a lens 47 or more to decrease chromatic aberration. Well, studies have proven that chromatic aberration also deteriorates the retinal image quality. So to conclude, patient satisfaction is not just a good Snell's acuity. It is important to look for ocular surface preoperatively, and to decide on the IOL, look into the preoperation of the aberrations and choose appropriate IOL, look into the condition of the zonules, look into the angle alpha, and make sure not worsening the aberrations following surgery. Thank you.